We have two of our neurotrauma team from Elmhurst joining us for a great talk on neurotrauma. Dr. Hickman is an assistant professor of neurosurgery in our department here at Sinai, and he's the director of neurotrauma at Elmhurst, which is a New York City Health and Hospitals hospital. He completed his training at Columbia, both MD and neurosurgery residency, and did a fellowship in neurotrauma and critical care at Miami Jackson Memorial Hospital. And his research interests focus on general neurosurgery, neurocritical care, and trauma, as well as intracranial multimodality monitoring, which is really on the cutting edge of how we manage brain trauma and brain injury. And then Dr. Jones is, like myself, among the new members of the department here, also an assistant professor in the department and associate trauma director at Elmhurst. He completed his medical training at UCLA and his neurosurgery residency at University of Maryland, where they have one of the top trauma centers in the country. So he had a really phenomenal experience there, as well as dedicated years in complex spine. He also did a fellowship at Weill Cornell in skull base and microneurosurgery research. He, as I did, joined the department just last year and treats a really wide variety of conditions, and has received a number of awards for his excellence in patient care. So with that, I'm going to turn over the screen sharing to Dr. Hickman so he can show the slides and leave the rest of the presentation to them.
All right. You seeing that okay?
Yep.
All right. So as Dr. Morgenstern mentioned, this is a webinar on neurotrauma. I'm Dr. Hickman. Dr. Jones is with us. We have no disclosures, financial disclosures or otherwise. I'm going to move on to the next screen, which is an outline of what we're going to go through. This is going to be a real kind of bird's eye view of neurotrauma, because obviously that's a very large topic to go through in 1 hour, and we want to leave time for questions. Also, we're going to specifically focus more on head trauma, although obviously neurotrauma involves both head and spine trauma, but our spine colleagues are going to go over spine trauma in their lecture. And you know, we treat both here at Elmhurst Hospital. We do all the spine surgery at our hospital here, which is nice from a neurosurgery perspective. So we're going to go over a little bit on the value of a dedicated neurotrauma experience and how that's valuable to you as a resident in particular. An introduction to neurotrauma, some of the basics of a neurotrauma evaluation, and then really get into some case examples from real cases here that we've had at Elmhurst that we can go over. Feel free to ask questions during those. I know Dr. Morgenstern is going to be helping collate some of the questions for later, but if there's something that he thinks is good to interrupt us about, then we're happy to answer questions as we go along. And then we'll have a little bit about the Elmhurst Hospital neurotrauma rotation for those that are planning on applying for residency positions for next year. A little bit kind of just a good overview of how the rotation here works, and then some questions and answers. So this is just a picture depicting some Incas doing some trephination. So, you know, neurotrauma is the oldest subspecialty of neurosurgery. So, you know, it's kind of has that pedigree. So I'm gonna hand it over to Dr. Jones to start with the value of a dedicated neurotrauma experience.
All right, thank you, Dr. Hickman. There's many reasons, you know, that we're having this talk tonight. And part of that is really geared towards medical students that are interested in thinking of a career in neurosurgery. I really want to urge upcoming medical students, you know, budding neurosurgeons to give a serious look at neurotrauma, you know, for a variety of reasons. There's many reasons to be excited about it as a career. And there's other aspects that are quite unique and beneficial in the training of, you know, budding neurosurgeons. One of the first things that comes to my mind is the variety of both non-surgical and surgical management. You know, within every subspecialty of neurosurgery, there is a mix of surgical and non-surgical management. But you can imagine, you know, if you primarily are a spine surgeon, if something is not operative, your involvement in a particular patient is going to be quite limited. Whereas in the neurotrauma patient, even if there isn't anything immediately operative, there you have a role in taking care of the patient through the acute period and in the post-acute period afterwards. And also as a junior resident, your neurotrauma rotations are often, very instrumental period of growth. There's a lot of quick and fast decision making, that has to be taught and learned, sometimes sort of trial under fire. There's going to be some honing of neurocritical care triage. This is true throughout all of your neurosurgical training, and once you're in practice, is how do you manage multiple critical patients at the same time? How do you triage which critical patient requires your immediate attention in that very moment in time? And again, that's very important as a junior resident, and it's something that you learn and you build, and it carries with you throughout the rest of your neurosurgery training and career. Part of that, again, as you're also triaging multiple patients, you're often communicating with multiple teams. It can be the trauma team, ICU team, the radiology team, nursing team. And at the same time, you're also communicating with patients and the patient family members more often than the patients themselves. And there's a certain tact and skill, to delivering unfavorable news or bad news, and also doing it in a way where time is important. If you need to get consent for an emergency procedure, you have to explain the situation to the patient's family members. At the same time, you have to be mindful of the important time is of essence. And certainly when you have a dedicated neurotrauma rotation sort of day in, day out, these are things that you're working at and learning how best to handle these tasks. And it's extremely important, especially when we move on to other areas of neurosurgery. How are you able to speak with patients, deliver bad news, and how do you manage to continue to instill hope at the same time, doing everything that's appropriate in getting informed consent about procedures and delivering important information about a patient or loved one's clinical status. Moving on, additional aspects that you learn and become sort of a master at is principles of ICP management. How do you manage a patient with elevated ICPs? Another entity we see quite often in neurotrauma are seizures, in particular status epilepticus. And there's, just as with any subspecialty in neurosurgery, there will be complications. They can be acute complications in the operating room, in the ICU, or more in the outpatient setting, and how you recognize, try to prevent, and manage those complications. All of those are important to building skills that would carry over to other areas of neurosurgery. And also, if you choose not to have a particular focus in neurotrauma, the skills that you learn are going to be useful no matter what you do and where you end up practicing. Once you get out in practice, with rare exception, you will likely be taking a general call, and that will include trauma. And trauma is something that is going to be present no matter where you choose to practice. And there's entities like compression fractures, subdural hematomas, subdural hygromas that are sort of almost ubiquitous. And with the demographics of our country, with the aging population, they're probably only going to become even more common. And if you don't have to travel too far out of our tertiary and quaternary acute care hospitals to really where you may find yourself as being the neurocritical care authority, as a neurosurgeon in a hospital. And you're not always going to have experienced neurologists or neurointensivists, at individual hospital where you're practicing. So it's important to understand and know, the fundamentals of providing neurocritical care, because you can and will be seen as a neurocritical care authority. And the other thing I would add is, and this is another benefit to our experience, at Elmhurst Hospital here at Mount Sinai, is that on the outpatient side, you have the ability to see patients in the outpatient setting. You get to follow them and see how they recover. You'll be amazed at the great extent of recovery that patients can and will have. It's sometimes hard to believe or see it, when they're in the intensive care unit, but it certainly does happen. Next slide.
So a couple of things I wanted to add to that too is that one of the, depending upon where you end up practicing, if you did decide to go into neurotrauma as a specialty, it's very frequent that you will have a second subspecialty almost. There are some folks that very busy level 1 trauma centers where all they're doing is neurosurgical emergencies, but generally speaking, the norm is that you would be, potentially the neurotrauma person and also do spine or also do general neurosurgery or has some other specialty. So in that way, it's nice because you get a lot of variation in that regard. Some do neurotrauma and critical care, and just one thing to keep in mind is any place that has a trauma center, any place that's either level 1 or level 2 trauma center is always in need of neurotrauma neurosurgeons. And so it is, compared to some other ones that may be more saturated, it is definitely a subspecialty where there's always in demand, and usually the demand is outstrips the supply. So that's always a nice kind of situation to be in. So I wanted to go through a little bit of an introduction to neurotrauma. Again, this is going to be pretty high level. We're not going to go into the nitty gritty of necessarily multimodality monitoring. What happened there? Okay. Can you guys still see the slides? Okay. Yeah. Okay. Multimodality monitoring or other aspects of neurotrauma care. I really wanted to keep this kind of to more medical student and beginning resident level. I can't remember where I heard this quote. It might have been Raj Narayan, I don't remember, but one of the things about neurotrauma, I heard a quote that was the most complicated disease in the most complicated organ system. Again, I can't remember where, but it was probably a neurosurgeon that said that. So, I think that's it's a good summary of neurotrauma. It's a very complex multifactorial disease, obviously affecting the most complicated organ system in the body. And I think a lot of us that specialize in neurotrauma find that very appealing. We like the kind of the pathophysiology and the kind of the both the not just the operative care, but the pre and post operative care of the patient as well. So, why is neurotrauma, or as I mentioned, we're going to specifically talk about traumatic brain injury. Why is it important? Well, it is by far and away the most common neurosurgical disease that you will encounter or that we treat both in the United States and worldwide. There's anywhere between around 2 million emergency department visits per year for traumatic brain injury. Now, obviously, the majority of those are concussions and don't ultimately need surgical care, but we're talking about 250,000 patients that are potentially hospitalized, and anywhere upwards of 50,000 deaths resulting from traumatic brain injury. And depending upon the situation you're in, you may be one of the authorities on concussions and mild traumatic brain injury in your hospital, like we are here. There's a high cost to society in terms of the actual financial costs, over $75 billion a year, and this data is even a few years old. And 1/3 of all trauma-related deaths are caused by traumatic brain injury. In the United States, at least, and Canada, falls are the most common cause of TBI, but if you with motor vehicles being second. But if you look worldwide, motor vehicle accidents are the most common and are actually increasing. So if you look, this is data from 2001 and 2010, so it's a little bit old, but this trend has continued. Really, at least in the United States, hospitalizations and deaths for traumatic brain injury really kind of remain flat, but the amount of emergency department visits have gone up, and that's likely due to the aging patient population, more subdurals, more falls, more kind of minor traumas resulting in head injuries. If you look worldwide, though, there's an overall increase in the amount of traumatic brain injury. A lot of that has to do with increasing use of motor vehicles in places where they may not have been as readily available before, but where they still don't have the mandatory safety features that they have in high-income countries like airbags and seatbelts, or they're not enforced all the time. So, I think there's a tendency for people outside of neurotrauma to be a little bit nihilistic about the improvements that are made in neurotrauma. But I would like to kind of contrast this with, for instance, the improvements we've made in treating glioblastoma in terms of improvements in outcome or survivability. But if you look at severe traumatic brain injuries in the 1930s and 1940s carried a mortality of upwards of 80%. And if you look at each succeeding decade, there's been a dramatic improvement in mortality for severe traumatic brain injuries. And now it's usually around 15 to 20% in terms of mortality. Now, obviously, that doesn't always necessarily translate into a good functional outcome, but there's more and more the patients that are surviving are having good functional outcomes. And a lot of this has to do with improvements in ICU care, as we'll get, as I'll mention later. But if you look at cost-effective surgical procedures, perhaps the most cost-effective surgical procedure we have, not just in neurosurgery, but overall, is really a craniotomy for an epidural hematoma. Obviously, a rapidly expanding epidural hematoma can potentially be fatal, and often is if it isn't surgically intervened upon in a prompt fashion. And most of these patients are young and have expected life expectancy that's long and can contribute to society. If they are intervened upon early enough, they will often have a very good outcome and actually return to a functional state and be able to go back into the workforce. So that's probably the most cost-effective surgical procedure that there is. Again, as I mentioned before, there is no real magic pill or silver bullet in trauma care. A lot of the improvements from the 1930s, 1940s till now, and improvements in outcome, both in mortality and functional outcome, are really from kind of multiple small victories that combined together have resulted in these dramatic improvements, including improvements in trauma systems and coordinated care, and improvements in EMS and emergency department resuscitation, improvements in intensive and neurocritical care. Neurocritical care as a subspecialty is really only kind of developed in the last 20, 25 years. And that has had dramatic improvements in outcomes for our patients, not just in neurotrauma, but in neurosurgical diseases and neuroemergencies all told. We can't forget about improvements in post-TBI rehabilitation and how, particularly patients with neurological insults, we all know, have very prolonged recovery courses in traumatic brain injury. That may be, at a minimum 6 months, but usually you're looking at a year or 2 years potentially, same as spinal cord injury. And the physical and cognitive rehabilitation that goes on in specialized centers can't be underestimated. And again, adherence to guidelines-based management, and really, guidelines have provided a good groundwork and a good starting point to treat these patients. Obviously, every patient is different, and you have to individualize the care to the particular situation and particular patient. But where guidelines are helpful, or as guidelines give a good basis of what is probably helpful to the patient, what is probably deleterious, and gives a good framework from which to go forward from. So a little bit on TBI classification. Again, I won't get into the nitty gritty of too much of this, but really just the take-home message I want to get across is that TBI really is not one disease. It's really a multitude of different diseases kind of wrapped up into one term, and there are many different ways to classify it. And one way is on the clinical severity, such as using the Glasgow Coma Scale or the abbreviated injury score. We can classify traumatic brain injury based upon the mechanism of injury, whether it's a closed traumatic brain injury or a penetrating one, which tends to have worse outcomes, based upon the force that is, and the type of force that has caused the injury. Radiographic parameters, which are often used in research settings, or the specific kind of pathoanatomical injury type, whether it's an epidural hematoma, acute subdural hematoma, diffuse axonal injury, global cerebral edema. And very frequently it's a combination of multitudes of these in different patterns and in different amounts. And so as you can see, we have kind of all these different pathophysiological aspects of traumatic brain injury, and they interact with each other in different degrees and different overlap in different amounts in every given different patient. So that's why it's often hard to generalize to an entire traumatic brain injury population. It's also one of the reasons why doing large multi-center trials is very difficult in traumatic brain injury. Just a little bit on the right there, you can see how, you know, the magnitude of the acceleration or the force of the injury and the duration, the interplay between those two really decides oftentimes what particular type of injury the patient has, with longer duration, longer magnitudes, resulting in more diffuse profound injuries like diffuse axonal injury. And this is just a famous slide kind of in the TBI world that we tend to all put in all of our presentations, it seems like. But the reason being that this is just a good visual representation of these are 6 different patients, all of which have a severe traumatic brain injury, all of which are comatose. And you can see, you know, they're not all going to be the same. They all don't, one has an epidural hematoma, one has mainly a contusion, one has diffuse axonal injury, one has diffuse swelling, etc. And not only is the treatment potentially different for all these patients, but also the prognosis for these patients is likely different. You know, somebody that has an epidural hematoma that's young, likely if you evacuate that in time before there's a secondary brain injury, that patient will likely do very well. Whereas potentially the patient that has diffuse axonal injury may either have a more prolonged recovery or may not recover to the same extent as somebody that has an epidural hematoma. So again, this is just an example of how it's multiple really different diseases all in one. So really, you know, one of the main principles is that in traumatic brain injury, we're really not treating, so to speak, or reversing the primary injury. You know, once somebody has a primary injury and loses neurons from that injury or irreversibly damages them, either with a contusion or from ischemia that results in an infarct or from a penetrating injury, there's nothing we can do to reverse that. So really all of our treatment is to prevent secondary injury from occurring to the brain. So we want to prevent hypotension, we want to prevent hypoxemia, we want to augment cerebral blood flow, because cerebral blood flow decreases after traumatic brain injury. So we want to make sure that the brain is getting enough oxygen, enough blood flow, enough nutrients, glucose, to make sure that the remaining brain stays functional. And then obviously if we have a mass lesion, such as an acute subdural hematoma here or an epidural hematoma, we may need to evacuate that or remove that to control somebody's intracranial pressure and prevent herniation. So all of these things can lead to secondary injury. And really that's in a nutshell what we're trying to do when we treat the patient with a traumatic brain injury, is prevent a secondary injury and hopefully then provide an optimal environment in which the brain can start to recover and start to heal itself over the ensuing weeks and months. So part of that, obviously, I think many medical students have seen this, heard of the Monroe-Kelly doctrine, but the Monroe-Kelly doctrine is a good way of thinking about what happens when you put in a mass lesion into the skull. Obviously, the skull is a fixed, rigid compartment, essentially, and 80% is taken up by the brain, about another 10% by the blood, mostly in the veins and the venous structures, and then 10% of CSF. And you can see in the bottom graph here, if you start to develop a mass lesion, which is represented by the brown structure on the diagram, that as that happens, initially that you can compensate for that increased volume by decreasing really the amount of venous blood or decreasing the amount of CSF in the skull. But at a certain point, you reach a point where that you've compensated as much as possible. And at that point, if you keep on adding more volume, such as an expanding epidural hematoma or increasing cerebral edema, your intracranial pressure is going to start to go up, and it starts to go up exponentially. And that's why one of the reasons why we have to, evacuate mass lesions, because obviously if the intracranial pressure goes up, we all know that somebody's cerebral perfusion pressure is related to their intracranial pressure, and that the cerebral perfusion pressure is the mean arterial pressure minus the intracranial pressure, and that's going to relate to somebody's cerebral blood flow. So basically this is just a classic diagram showing that if your cerebral blood flow drops a little bit, then you can probably tolerate that for quite some time without resulting in a irreversible injury or an infarction. And you might have a reversible deficit, but presumably those neurons will be able to recover once the cerebral blood flow recovers. However, if your cerebral blood flow drops significantly, then you have much less time in which to intervene before previously viable brain tissue becomes irreversibly injured. And we know that in a traumatic brain injury, that after traumatic brain injury, there's a dramatic decrease in the cerebral blood flow. And then if you're adding mass lesions on top of that, increasing the intracranial pressure and decreasing the cerebral perfusion pressure and the cerebral blood flow, that the brain is in a state where it is very, very sensitive and very, very susceptible to additional injuries. Again, don't try and memorize this, but this is just a schematic to show that not only do we have all these macro phenomena going on, but after a traumatic brain injury, there are many events going on both at the neuronal level and at the membrane in the neuronal level, including influxes of calcium, increases in excitotoxic or excited neurotransmitters, excitatory neurotransmitters that can be toxic, as well as mitochondrial dysfunction. So really, after traumatic brain injury, you're in this situation where basically the brain is in this essentially a metabolic disarray, and it requires a significant supply of glucose and oxygen just to kind of prevent additional injury from occurring, let alone start the period of recovery. So it is very susceptible to any sort of perturbation in kind of normal parameters. Just looking at some important prognostic indicators, the most important after traumatic brain injury or age. Can't really do much about that, but it's been shown that over the age of 40, these patients tend to recover less robustly than ones that are younger. There's probably a second cutoff somewhere around the age of 70 or 75. Glasgow Coma Scale, so the severity, again, really what we're talking about here is really the post-resuscitation GCS. So it's important to realize that hypotension, hypoxia, increasing mass lesions, seizures, medications, these can all affect GCS. And so it's important to try and minimize the confounding from these as much as possible. And then pupillary reactivity. But additionally, other prognostic indicators are important, are these modifiable ones. And these are really what we try and deal with essentially to prevent secondary brain injury. So again, hypotension, hypoxia, hyperventilation. So excessive hyperventilation is bad. A little bit of mild hyperventilation might be okay if somebody has increased ICP for a brief period of time, but should be aware that increasing the excessive hyperventilation or prolonged hyperventilation is going to decrease the cerebral blood flow and potentially cause cerebral ischemia. And then obviously preventing herniation. And if you go to the TBI Impact website, they have a prognostic calculator that you can actually plug in a lot of these variables and basically get a sense of what the expected prognosis for a patient might be at 6 months. So you can kind of, I encourage you to go there and play around with that. But you can, I'll use it often frequently, more when I'm discussing with patients or with patients' families really about, kind of what to expect potentially. Because it does provide some numbers that you can quote kind of. So I think Dr. Jones was going to go over here the basics of the neurotrauma evaluation.
Next slide. All right, so this next part, we really want to see how do we evaluate the neurotrauma patient. When a patient comes in, you're going to get information from the EMS team. If they're brought in by ambulance, there'll be some initial information from family members or witnesses. In the event of certain traumas, there's things you'll see on inspection and on exam on CT scans. But really, even before you dive into, what a CT scan might show, it's important to remember the basic neurotrauma evaluation begins with the initial trauma evaluation. Next slide. And trauma is a team effort. So when you're seeing a patient in your trauma bay, there's certain things you'll be thinking of, but then your trauma team, anesthesia team, emergency room physicians, those teams will be thinking other things, but really the key things are going to be your basic A, B, C, D, E's. And in line with what Dr. Hickman has already said, at least twice now, is we really want to try to avoid early periods of hypoxia, of hypotension, and certainly you don't want to cause any additional secondary injuries from, for instance, say a missed unstable, cervical neck. All of those events can drastically reduce the likelihood of good outcomes. And so, fortunately, again, trauma is a team effort, so you don't have to always be the definitive expert on, managing someone's airway, breathing, or circulation, but you want to be aware as to the overall status of the patient when they arrive. When you assess the airway, you want to check to see if the airway is patent. You don't want it to be obstructed. If it's deviated, that could be important to know. Or in some instances of trauma, the airway may be crushed, and there's appropriate indications for intubation. And even as a patient presenting as a traumatic brain injury, you want to secure the airway before you even think of moving them into a CT scanner. Now, breathing is a little bit different. It's really centered upon making sure that there's adequate delivery of oxygen. Again, you don't want to have any periods of hypoxia that only worsens your traumatic brain injury and worsens your long-term outcome. Similarly, circulation, you want to make sure that you don't have any periods of hypotension. Disability is also important, especially if you happen to be managing a patient outside of the hospital setting. Let's say you stop on the side of the road to help an accident before EMS has arrived. Disability is you want to check and see, are there any obvious extremity injuries. Some injuries you may only suspect but you won't know until you get X-rays or even CT scans. So you want to do protective measures such as immobilizing someone's cervical spine and being aware that exposure has its own meaning to the trauma team. But for neurosurgeons, if someone has scalp lacerations or skull fractures, oftentimes you want to get very good exposure to really clarify what is the severity. That can involve clipping of hair, checking to see if there's underlying fractures, if there's CSF leaking through fractures. Those are all very important and very basic, even before you have additional information from radiologic studies. All right, next slide.
Sorry, 1 second. Interesting. There you go.
That goes into just some initial goal physiologic parameters. These parameters are not absolute, but it's important to have an idea of what the goal should be or what they should look like. A PaO2 of 60 millimeters of mercury correlates with an SpO2 of 90%, but very often we have even higher, ideas of what the goal should be. And certainly it's important to know that if a patient is not meeting one of these goals, let's say their ICP is high, their PaO2 is low, their pulse ox is low, or they're acidotic, you really want to investigate what those causes might be. Okay. Next. That leads us to the next slide. Again, it's going to sound repetitive, but it's incredibly essential, incredibly important. That's this idea of a traumatic brain injury bundle. Everything we've said thus far regarding some of the pathophysiology and some of the initial management. Again, you want to try to avoid hypoxia, try to treat reversible causes, similar with hypotension. Some mild hyperventilation can be reasonable in the acute setting, but you don't want to excessively hyperventilate the patient. And notice, the next item, evaluate and treat intracranial hypertension. If there's any mass lesion, if it's of an operative size, you want to address that. But notice that doesn't come at the top of the bundle. That's only the fourth, because again, it goes back to your ABCs of trauma evaluation. And also, steroids are really not indicated or haven't really been shown to be beneficial, in fact, rather detrimental in the traumatic brain injury patient. All right, next slide. And there's no way to really teach neurotrauma, in a 1 hour talk. And it's certainly important to be aware of guidelines, which are really, they're not absolute rules. They're recommended best practices. There's very smart people that sit around and think about how can we best treat large groups of trauma patients. So it's very important to understand their guidelines. And as a resident on a dedicated neurotrauma experience, it may seem like a lot, but you will actually become quite familiar and have all of the guidelines memorized, really through experience rather than group memorization. But guidelines change with time. There's always new research that we take part in, but we're not alone in that. So it's important to follow whenever new guidelines certainly come out. Now we'll get into some of our case examples.
Just want to interrupt you guys for a second because there was a good question about vasospasm. So,
yeah.
We know that vasospasm is common in aneurysmal subarachnoid hemorrhage, and I personally have seen it a couple times in trauma, but anecdotally much less often. What is your experience, higher volume trauma experience?
Yeah, so it's one of those subjects, again, you can probably talk about for an hour, and I have before, but it's probably somewhat under-recognized because we don't look for it as often. Often when we're getting a CTA, we're doing it usually right away to see if they have a blunt cerebrovascular injury. And if not, we're not necessarily following them up routinely with other ones. But if you do look, or you're monitoring with TCDs, you will see that particularly in really severe head injuries, and it really seems to correlate with the amount of force and the amount of energy that's transmitted to the vessels, that these patients can have traumatic vasospasm. When I was a resident, some of the worst vasospasm I saw was actually in trauma patients, but they were patients that typically were severe TBIs. It is correlated with GCS. So the lower the GCS, the more likely to have traumatic vasospasm. We do know that it's different than aneurysmal subarachnoid hemorrhage vasospasm in that it typically occurs earlier. It typically does not result in infarction or neurological deficits as much, but again, that may be because we're confounded by the fact that these patients are already comatose and we're not looking for it as much. It tends to resolve quicker, really, over the course of days as opposed to over the course of weeks compared to aneurysmal subarachnoid hemorrhage. And it doesn't typically correlate with the amount of traumatic subarachnoid hemorrhage. So that's one important thing, is that you can get traumatic vasospasm without traumatic subarachnoid hemorrhage. In fact, some of the people that get it the worst really are blast injury patients, military. That leads us to believe that the pathophysiological mechanism by which it occurs is probably different. There may be a component that is related to the blood, but it seems to be probably direct energy transmission into the vessel walls, and that's probably why it occurs relatively soon and resolves sooner as well. Again, there've been several trials looking at nimodipine for traumatic vasospasm. None of them have shown a benefit, but again, they were also usually taking kind of like all comers as opposed to really focusing on the groups that might be the most susceptible and to traumatic vasospasm. So do I use it? I use it if somebody potentially is at high risk for it, but only if it's not going to cause a problem. In other words, only if it's not going to make them hypotensive and they're maintaining their blood pressure, because I know the hypotension is going to be bad for them. Whether nimodipine is a benefit or not, don't know.
One other question before you get to the cases that I think should definitely be answered is, can you guys just comment on how steroids were eliminated from neurotrauma care in the brain?
Yeah, do you want to take that one, Dr. Jones, or I can chime in for that one too?
You can go right ahead.
Well, in the crash studies, basically what they showed is that on the whole, and again, it's one of these things you have to be careful about what it's really saying. What it's really saying is that the use of high dose steroids for ICP control or to improve outcome after a severe traumatic brain injury isn't effective. So that's what it was looking at, and that's what we mean when we don't use steroids. But it's also equally valid to say that there are some instances when you may, and so it's not one of these things that you have to be careful about generalizing it. So for instance, a patient that has a chronic subdural Well, we know, there's a lot of people that give steroids for that. Also, a patient that has, like, say, an epidural hematoma that is several days out and is awake, alert, but has a horrible headache that won't go away, probably because they have an element of dural irritation and meningismus from the blood products that it's causing. Well, that's a patient that oftentimes, anecdotally, if you give them steroids, their headache goes away, they feel great, and they're able to get out of the hospital. So again, it's not one of these things where it's all or nothing, but you shouldn't be giving high dose steroids to treat cerebral edema after a head trauma or to decrease ICP after head trauma. Most of the cerebral edema is likely cytotoxic and not vasogenic, and that's partly probably why it doesn't help. And keeping them on the steroids long term really increases the complications from the steroids. So that's really what it's saying.
Dr. Marbenstein, I had a question regarding the intracranial pressure in neurotrauma. Can you hear me?
Yep.
Okay. All right. So based on what I've read and understood, some institutions prefer using mannitol versus hyperosmolar saline, or hyperosmolar saline versus mannitol for different reasons. So I wanted to know what was your take on it, and which one do you guys prefer using?
Yeah, so obviously both are hyperosmolar agents, but have dramatically different mechanisms of action. Mannitol obviously is a diuretic. It also may have some rheologic properties that make the red blood cells able to kind of deform and get into smaller blood vessels easier, whereas hypertonic saline is really a volume expander. Typically, what our go-to is it really depends upon the situation, but ideally, if you're able to give somebody hypertonic saline, that's usually going to be our go-to. And the main reason is that it's going to preserve somebody's blood pressure and not drop their blood pressure like mannitol may do. So mannitol, if we give it, we're always on the lookout to make sure that we're not decreasing somebody's blood pressure. So we know the hypotension is going to potentially be detrimental. Somebody that has a severe traumatic brain injury patient that has a single episode of hypotension below a systolic of 90, the mortality rate goes up by about 100%. So generally speaking, we'll stick to hypertonic saline. The caveats to that is, generally speaking, you want to give it, if you're giving like 23%, which is what we typically use if somebody's herniating or has really elevated ICP, you want to give it through a central line or through an interosseous line. You can give it through a peripheral line in an emergency, but you have to be careful not to have extravasation. And there's been no head-to-head study of mannitol versus hypertonic that's shown that one is better for the other for ICP control. So in terms of ICP control, they're both, in my mind, equally valid. There's just different scenarios where you may use one over the other. So may use mannitol if that's what I can get quicker and the patient's blood pressure is going to tolerate it. Whereas if I can get both into the patient in an equal amount of time, then I would probably opt for the hypertonic saline. So that's kind of the way our protocol is written, is to give either, but generally speaking, to err on the side of giving hypertonic saline when possible, and reserve the mannitol for when we can't get it or we don't have access.
You want to go into the cases?
All right.
Sure.
We can jump into our first case. We'll try to go through this and keep in respect to our time. This first case is, a 37-year-old male that brought into Elmhurst Hospital by EMS after an assault. He was intoxicated, altered, confused, unable to get any additional history. But he seemed to be, holding his own, relatively awake, following commands, moving all extremity with no motor deficits. The GCS of 13. His CT scan, there are certain things that are concerning, but overall, you might not be too impressed. Nothing immediately operative on this. He has a left-sided, extraaxial collection. There's some cerebral edema. There's some traumatic subarachnoid hemorrhage. There's some slight midline shift to the right side, and there may be some layering of some blood along the tentorium. But there's no individual mass lesion that requires an emergent neurosurgical intervention. Next slide. But in the trauma world, sometimes things change. And for this patient, within a matter of a couple hours, I went down and saw the patient who's no longer following commands, nonverbal, only localizing to pain, very lethargic, and very concerning. We were able to get another a CT scan, and we can see that on the next slide. And really, just in a matter of hours, this extraaxial collection rapidly expanded. And it becomes more apparent that it is in the epidural space rather than a subdural hematoma. So we had a rapidly expanding epidural hematoma, and it's possible that he had been unconscious at the time of his assault, and when he presented was quote unquote in his lucid interval. But oftentimes the history is not perfect. Again, we were unable to know more about what actually happened at the time of his assault. But that is certainly possible and could fit. He was taking he was rapidly intubated in the emergency room, taken to the operating room for evacuation. You can see this on the next slide. Post-surgery, he had an ICV monitor placed, which is standard protocol for this patient was now a severe TBI patient. This particular patient had a very prolonged ICU course. I remember vividly going in, seeing him, examining him, and talking with family. And it was quite suggestive that he had a very dense aphasia. Often we saw also in his CT scan he had developed a quite extensive left temporal contusion. And even after he had stabilized and no additional ICP issues, he was extubated. But for the first 2 weeks after the trauma, he didn't speak a single word, and he just stared at you. He would follow some basic commands, and he's ultimately discharged to TBI rehab. We go to the next slide. And when I saw him back, at 6 months, I had seen him multiple times before 6 months, but by 6 months, he was doing much better. He was speaking, had no speech deficits, whatsoever, no motor deficits. He was back working a job in a restaurant. He felt that he had no issues with speaking with his significant other. There were some mild memory deficits where the short-term memory was affected more so than long-term. But overall, this case shows how the importance of a timely neurosurgical evaluation, prompt recognition of changes in someone's exam, and the swift decision making and emergent surgical intervention, and along with continued ICP management, ICU care. With all of those efforts, we really can achieve some very good outcomes. That really makes all of our work very worth it. All right, moving on to our second case. It's a little bit different, where this patient did not present in some acute period after a trauma. He's a 56-year-old male brought in by his friend, because over the past week he had been having very intermittent episodes of trouble speaking and right upper extremity shaking. The history really was reminiscent of having some partial seizures. And on exam, again, he had no neurologic deficits at that time. Again, which also supported that he had been having just intermittent seizures with perhaps a mild Broca's aphasia. He did have some midline shift, but he was started on anti-epileptic. And similar to other areas of neurosurgery and trauma, we try to advance our field and progress it along. Go to the next slide. And so for this patient, we initially started using this what's called a SEPS, which is a subdural evacuating port system. It's really you drill a burr hole to tap into an aged subdural collection where the blood products have thinned out and the collection itself is quite thin. And once you tap into it, very often the fluid will just emanate out. And this is quite nice in the sense that it provides quick relief of mass effect. It allows you to really drain the collection with minimal use of sedation, and oftentimes avoidance of an operating room or any general anesthesia experience, which is very favorable in frail elderly population where we see this more commonly. So this was tried in this patient and actually did not work. So even when you think you have things figured out, neurotrauma always has something something up his sleeve. So we can move on to the next slide. And, this patient was taken to the operating room, and when you open, you do a large craniotomy flap, you open up the dura. This is often what you see. And when you open up the dura, the first thing you should, be seeing is, a nice layer of arachnoid covering the surface of the brain. In this case, we see this extraaxial collection. What looks like it has, a membrane. There's certainly an outer membrane, we call it like a parietal membrane to it. We can go to the next slide. You see, once you go through that, then you get into this, some of the older age, breakdown products of blood that would have occurred in the earlier stages of, an acute subdural hematoma, or instances where you have recurrent bleeds, in a chronic subdural hematoma. And this is evacuated very often, as we see on the next slide. It's once you evacuate all of that, sometimes there is even an inner membrane that is draped over the surface of the brain. And if you look, you may be able to see the actual gyral pattern of the underlying brain. There's a very thin membrane onto the brain surface. Sometimes it's very adherent, other times you're able to safely remove it, but it's not always. And if it's not easily removable, usually trying to remove it leads to more problems. But this is another situation. We move to the next slide where we were involved with his care, not at the acute period when he initially had his trauma, more so in a subacute to early chronic period. And by 6 months, he again was doing well, had no more episodes of these seizures. He actually was weaned off of the anti-epileptics. He underwent left middle meningeal artery embolization. That was done by Dr. Kellner, as one of our vascular colleagues here at Sinai. Not every center is doing this, but certainly we think this is part of the management of chronic subdural hematomas, and will be likely standard in the near future, with a very low risk of recurrence rate of about 3% in the large major meta-analysis. But we were able to do that, and his most recent CT scan, shows no signs of recurrence. So we're very thrilled with his outcome. But it goes to show that, even if he had presented at the initial phase of his trauma, there likely would not have been anything that he needed immediately. But you continue to follow these patients, and oftentimes they may need an intervention later, coordination of care with multiple teams, and in this case, with our Sinai vascular team.
So I'm going to go through these next two cases relatively quickly. Really, the reason why I chose both of these two cases, this one, the one following it, is that these are patients that initially you might presume are going to do very poorly, so I'm probably giving it away. But both of them, what they both have in common is they're both relatively young, and so not to be ageist, but as we mentioned before, age is a significant prognostic indicator, and generally speaking, somebody that's young, and by young I mean even into their 30s and early 40s nowadays, more than likely they're going to have a chance at a neurological recovery if you can prevent there from being a secondary injury. And so, we tend to be quite aggressive with patients that are younger, because I have seen some pretty remarkable recoveries that I initially may not have assumed were going to be the case. And so I kind of wanted to highlight a couple of those. But, this is a 24-year-old that came to us a couple of years ago, actually, and he had been, whether it was self-inflicted or his friend, but basically the story was that they were playing with a gun, low caliber gun. So it was a 22. If this had been like a 45 caliber, I'm sure that he would not have survived. But basically a midline gunshot wound to the forehead that went right through the ACA territory vessels, right down the midline, right into, and presumably through the thalamus. It probably went a little bit above it, which may be why he did so well. But he had some poor prognostic indicators when he came in, including the fact that both of his pupils were fixed and dilated, and the fact that he had midline injury with an extensive IVH. So initially, I thought he was actually going to do very poorly. I wasn't convinced that he was going to survive, and typically in the patient with penetrating injury, if they have worse prognosis than a blunt injury, and if they've lost brainstem reflexes and have significant poor prognostic indicators, including midline or mid-brain injury, then, we often won't take them to the OR. But, given the fact that he was very young, this had just happened, I wanted to kind of see, if he would respond, at least initially, to medical therapy. And so, in the emergency department, he was intubated and resuscitated. And what I mean by that is, we made sure that his blood pressure was not low, that his blood pressure was adequate, that he was not hypoxic, and that his GCS was really, was not being confounded by those. I also gave him empiric hyperosmolar therapy and anti-epileptics on the off chance that, either his exam is being confounded by seizures, or that if hyperosmolar therapy is going to, empirically decreases his ICP, maybe he will regain some brainstem reflexes and pupillary reactivity. And sure enough, I was on my way into the hospital. We gave him hyperosmolar therapy, and by the time I got there, he'd regained pupillary reactivity, and his GCS had improved by 2 points to 7. So that told me that, he had potentially salvageable neurological function. So we took him immediately to the OR. I didn't even bother putting a monitor at that point. We just took him straight to the OR to do a bifrontal decompression, bifrontal craniectomy, debridement for infection control, local debridement. You don't want to go digging around for bullet fragments that are deep, because that will get you into bleeding that you might not be able to control, and placement of ventriculostomy. And post-operatively, he had a long course. His post-op ICU management included medical therapy for ICP control, obviously antibiotic infection control, which is, it's controversial which antibiotics to use and for how long, but we typically, or at least I typically, will do 5 to 7 days of broad spectrum antibiotics, including anaerobic coverage with flagyl. Seizure prophylaxis, again, controversial for how long, although the evidence of continuing seizure prophylaxis, even in penetrating injury, even though the risk of epilepsy is higher, if you haven't had an early seizure, there's really not much evidence to continue it longer than a week, but some places do. And I just wanted to highlight that he had pretty much every medical complication that occurs with high frequency from a penetrating brain injury. He had ventriculitis, he had hydrocephalus, he developed a CSF leak, anterior CSF leak that I had to repair. He also had a cranioplasty after infection, after I did this cranioplasty about 6 months out. All in told, I operated on him 8 separate times. Not all on the initial presentation, obviously, several at the beginning, including his shunt for his CSF leak, but overall 8 procedures. He was discharged to acute TBI rehabilitation, and this is a scan from about a year out, but after his second cranioplasty, and his ventricles look large, but a lot of that's ex vacuo ventriculomegaly from the brain tissue loss in the frontal lobes. But at 18 months of follow-up, he was GCS 15, no motor weakness, actually came to clinic independently using his phone. He obviously had some persistent personality cognitive changes from his bifrontal injury, but doing very well overall. So it's just an example of how somebody that you may think that, is destined to not make it, or to be vegetative, or have a profound injuries, can do well. And it's very hard to tell at the beginning whether somebody's going to do well or not, unless they have something that's obviously a fatal injury. This is another one, and obviously we want to get to questions, so I'll just really quickly go through this. This is, again, another young person, pedestrian hit by a car, hit the windshield, initially came in with a good GCS, but had a subdural, and had this, the reason why I put this bone window has a concerning feature, which is a fracture that goes right over the sagittal sinus. While he was in the scanner, he decompensated, declined to GCS 3 very rapidly, and blew his pupil, became bradycardic. So obviously, a Cushing type response with some hypertension, indicative of likely, increasing mass lesion on the left side with elevated ICP. Was emergently intubated, mildly hyperventilated, given empiric hyperosmolar therapy, taken to the OR for decompressive left hemicraniectomy, evacuation of his acute subdural. But in the OR, after the evacuation of the acute subdural, had rapid swelling of his left hemisphere. And there's multiple different things that can cause this, including a new ICH on the same side, or fulminant cerebral edema. But the reason why I put up that picture of the skull fracture is that immediately when we see that, what we're always concerned about is if there is an injury to to the venous structures underlying that fracture. So if it's going across a dural sinus, very frequently you can have an injury to that dural sinus. So in his case, he was immediately taken down to the CT scanner, and sure enough, he had basically a midline, but midline and kind of contralateral epidural hematoma resulting from bleeding from the superior sagittal sinus. And the reason why this occurs is when you decompressed with a hemicraniectomy and decompress the original injury, all of a sudden you've taken away that tamponade effect, and you can end up having bleeding. So anytime you see a fracture crossing a dural sinus, always be concerned about development of an epidural hematoma from that. So again, he went back to the OR, had this evacuated. The reason why I kind of put up these next steps are these are all things you can do in the operating room when you have that fulminant swelling to try and mitigate it, including elevating the head of the bed, hyperventilating, giving hyperosmolar therapy, putting in a ventriculostomy if you don't already have one. Consider using an ultrasound. An ultrasound will help you determine whether or not you have a new ICH on the same side that you could evacuate. You're not going to be able to see across the entire brain, but if you do a quick ultrasound, if you have one already set up and you don't see anything, then you can assume that it's either fulminant swelling or there's a contralateral hemorrhage. And if you see an ICH on the same side, you might be able to evacuate it. If you really can't get the scalp closed, you might need to consider doing an anterior temporal lobectomy or even a frontal lobectomy, and then getting post-op imaging. So he went to the OR. He had the epidural hematoma evacuated. The sagittal sinus got hemostasis from the superior sagittal sinus. Had an ICP monitor placed, and he had significant swelling post-operatively. He doesn't have any midline shift here, but he has kind of global cerebral edema, and he went through our usual tiered ICP management, including paralytics for him. And the reason why I bring him up is that, pretty much, there is, both the trauma team and the ICU team were constantly telling the family, or we're very pessimistic, I should say. But given his age and given the fact that he had no strokes, nothing on any of his CT imaging initially that would indicate that he was definitely not going to do well. We were very aggressive in managing his intracranial pressure and his cerebral perfusion pressure. And in fact, I allowed him to even have a slightly higher than normal ICP just so that we can maintain a cerebral perfusion pressure. And he had a very long course with acute respiratory distress syndrome, had a trach and a peg, had a hospital ICU length of stay of almost a month and a hospital length of stay of almost 2 months, went to acute TBI rehab. And I probably should have put the video up here, but I couldn't find it. But at 12 months post-op, he was basically returned to work. So GCS 15, no focal deficits, actually had dinner with him and his family, which was very nice. So again, one of these people that you might be a little bit nihilistic and think things are not going well even a few days after his injury, but some of these patients do very well. So I know we're going over time here, but I see we still have 92 people here. Yeah, I'm happy to.
One additional question. And we've answered a lot in the QA box, and we took some in the middle.
Yeah,
but
sure.
Does anyone have one last question for us for tonight? That was a great overview, both of you, and I think it really highlights, the highs and lows that you can get in neurotrauma, and also the complexity of what we can do. I think not everybody looks at trauma as the most complex of neurosurgical specialties, but it is for those of us who know something about it.
I did want to just highlight that, for those of them, the participants that are going on into applying for neurosurgery residency, at our rotation here, you spend a full year out of your residency here with us, 6 months as a chief and intern, and there's 3 full-time neurosurgery attendings here. It's really a combination of neurotrauma and general neurosurgery. So if you look at, and you have a fleet of PAs that help and run the service, but really the chief resident runs the service with the intern, with us supervising. So you get a lot of independence here. You're involved in every case. The interns in the OR and doing bedside procedures from day one. But really what we deal with is about 40 to 50% neuroemergencies, and the rest is a combination of elective spine and brain tumors. We're one of the busiest emergency departments in the nation. And we have a very high percentage of neurotrauma for the amount of trauma that we get here. We get about 1,400 or so traumas here, but about a third of those, quarter to a third of those are neurotrauma patients.
So here's a good last question. For patients who are coming in with an initial scan, what are the things that you look for that tell you that they're just very unlikely to do well? I know there are exceptions that prove the rule, but what do you look for?
Dr. Jones, do you want to take that one first?
Sure. Again, it all comes back to the neurologic examination. If someone has a very sort of damning CT scan, but their exam shows that they have a potential to recover, that they're salvageable, absolutely, you do everything you can, but the the opposite can also happen. Patients can come in with a very poor exam with even a normal or normalish appearing CT scan, and that person might have a very severe case of diffuse axonal injury. So they don't always correlate, but certain things that you see, such as hemorrhages in the brainstem, multiple sort of contusions in large elephant areas. If there's infarcts, such as in posterior cerebral territory, that can indicate that if someone has a lot of cerebral edema and herniated, that they've probably been herniated for quite an extensive time, and a surgical intervention is likely not going to change that outcome. But again, really you want to rely on what is the patient's exam, and if you're unsure, again, like many times you can be unsure. There's other things going on. They're hypothermic. Their toxicology screen is positive. Then really have to assess the CT scan and really err on the side of caution and give them the benefit of the doubt. I think, but
no, I would agree. And there, I think in terms of the CT scans, if there's things that I would consider essentially unsurvivable, or you're not going to survive and not be vegetative, or things that are like significant brainstem injuries, bilateral thalamic injuries, things like that. Somebody that's lost brainstem reflexes, again, it depends upon everybody's different, and it depends upon different factors. But if you're young and it just happened, that's somebody, if you intervene upon quickly enough, they may actually regain function. And it's a lot of times it's a self-fulfilling prophecy, right? If you wait then to intervene upon them, well, of course they're not going to do it. But a lot of the times we kind of we'll if somebody's young and they just had the injury, and even if their exam is poor, as long as they don't have something that that seems definitively fatal, we'll often err on the side of intervening. Can always withdraw later if they're not improving to the extent that you would think, or they have evidence of additional injuries later. But particularly in that initial in the ED, that initial time is very hard to predict. So we usually we're